Hello and welcome, fellow student doctors. Today, we will discuss internuclear ophthalmoplegia, which is an extremely high-yield syndrome to understand as it classically occurs in patients with multiple sclerosis. Friends, you will be tested on this, so learn it well. The name internuclear ophthalmoplegia tells you a lot, as internuclear means between nuclei. What nuclei? Cranial nerve 6 and 3 nuclei have a communication issue resulting in ophthalmoplegia, with ophtho meaning eye and plegia meaning paralyzed. So, one eye is paralyzed to medial movement due to an internuclear communication problem between cranial nerve 6 and 3. Why is there a communication problem? Well, the highway between those nuclei is damaged. The medial longitudinal fasciculus is damaged, as we will see. A lot can be discerned about a patient's health just by asking them to look to their left and to the right and watching how their eyes move. We are in for some fun, friends. Let's go ahead and get started. To prepare you for test day, you will be able to 1. Diagnose the following conjugate gaze palsies: frontal eye field, paramedian pontine reticular formation, cranial nerve 6 nuclear, cranial nerve 6 nerve fiber, and medial longitudinal fasciculus lesions. 2. Know that multiple sclerosis is a classic cause of an MLF lesion, leading to an internuclear ophthalmoplegia. Internuclear ophthalmoplegia is a conjugate gaze palsy. So let's start by discussing conjugate gaze, which is the ability of the eyes to look in the same direction. Imagine that these eyeballs represent a patient looking at you, and as such, are labeled patient's right and patient's left. If we ask the patient to look to their right, we see that both eyes move to the patient's right. Similarly, if we ask the patient to look to their left, we see that both eyes move to the patient's left. By observing this on physical exam, we know that the patient's ability for lateral conjugate gaze is working, which indicates that all of these elements are functioning. On the next few slides, we will briefly discuss these structures, saving the pawns for later so that you can diagnose several gaze palsies, which are often listed as answer choices on the exam as answers or distractors. The frontal eye fields, located in Brodmann area 8 of the frontal lobes, starts the entire process of conjugate gaze, that is, looking left or right. The key point is that a frontal eye field pushes both eyes to the other side of the body. For example, if the left frontal eye field located in the left frontal lobe of the brain becomes activated, it pushes both eyes to the right. Conversely, if the right frontal eye field located in the right frontal lobe of the brain becomes activated, it pushes both eyes to the left. Overall, when you are not looking to the left or the right, it turns out that both the right and the left frontal eye fields are active and push the eyes towards the midline, so that at rest our eyes look forward. To make sure you understand this, let's say that a patient has a stroke involving their left frontal eye field on their left frontal lobe. Which way are the eyes going to deviate? To the patient's left, because the right frontal eye field is now functioning unopposed, pushing the eyes to the left. In the setting of a frontal eye field frontal lobe stroke, the eyes are said to look to the side of the lesion. Here, the lesion is on the left frontal lobe eye field. So the eyes look to the left due to unopposed stimulation from the functioning right frontal lobe eye field. Cranial nerve 6, abbreviated CN6, also plays an important role in conjugate gaze. For example, let's tell the patient to look to their left. Then we will see this. This finding suggests that something is wrong with the patient's left eye, as cranial nerve 6, the abducens nerve, is not able to activate the lateral rectus of the patient's left eye to enable that eye to look to the patient's left. Cranial nerve 6 is called the abducens nerve because it abducts the eye via the lateral rectus muscle. Here is what a right cranial nerve 6 palsy looks like. This patient was asked to look to their right, and, as the red arrow shows, the patient's right eye was not able to abduct due to failure of cranial nerve 6, the abducting or abducens nerve. As a side point, A cranial nerve 6 palsy classically arises in a patient with idiopathic intracranial hypertension, as cranial nerve 6 has a long course within the cranium and is affected by increases in intracranial pressure. Cranial nerve 3 and the medial longitudinal fasciculus, abbreviated MLF, together play a key role in conjugate gaze. Let's see how by asking the patient to look to their left. As we can see, the patient's right eye does not adduct or move medially. This is because the patient's right MLF did not communicate with the patient's right cranial nerve 3 to activate the medial rectus muscle to move the eye medially. Congrats! You just diagnosed a right MLF lesion, which is called a right internuclear ophthalmoplegia. On the boards and the wards, this patient should be evaluated for multiple sclerosis. The boards love to try to confuse you between an internuclear ophthalmoplegia gaze palsy and a cranial nerve 6 gaze palsy. The key question to ask is which eye is stuck and cannot move on horizontal gaze. So let's ask our patient to look to their left. As you can see, the eyes highlighted in yellow did not move, but for very different reasons. The patient's left eye in the top panel did not move to the patient's left due to impaired abduction caused by a left cranial nerve 6 or abducens nerve palsy. On the boards, this is classically associated with idiopathic intracranial hypertension. The patient's right eye in the bottom panel did not move to the patient's left due to impaired adduction caused by a right MLF lesion, which is called a right internuclear ophthalmoplegia or INO. One very logical way, as this slide demonstrates, to remember these lesions is to realize that the abducens nerve, cranial nerve 6, is responsible for abduction of the eye. Meanwhile, the MLF is responsible for adduction of the eye. Both are responsible for ipsilateral coordination, such that the left abducens controls the left eye's abduction, and the right MLF controls the right eye's adduction. I want to note that the MLF works with cranial nerve 3 to cause adduction of the eye. But really, for your understanding, know that the MLF is responsible for adduction of the eye, because pure cranial nerve 3 palsies cause the eye to turn down and out with or without pupillary dilation. For more information on cranial nerve 3 palsies, watch my video on pupillary control. With that background, let's go through the neural circuits responsible for conjugate gaze. Again, we have the patient's eyes looking at you with the labels patient's right and patient's left at the top. We are going to ask the patient to look to their right. This all begins in the left frontal lobe eye field, which, as you know, is responsible for moving the eyes to the right. Notably, the left frontal lobe eye field sends neuronal projections that descend and cross to the contralateral side of the brainstem to synapse in the right pons. Specifically, a structure called the PPRF, or the paramedian pontine reticular formation. The right PPRF sends projections to the right abducens or cranial nerve 6 nucleus in the pons. The right abducens nucleus sends two key projections. The first key projection is, as you would suspect, the right abducens nerve, or cranial nerve 6, which goes up to the right lateral rectus muscle of the patient's right eye and activates it to cause the patient's right eye to abduct. The second key projection the abducens nucleus in the right pons sends is the left MLF. Yes, the right abducens nucleus sends the left MLF because the MLF is named for its destination, which is the left cranial nerve 3 nucleus in the midbrain, which sends neuronal projections along the left cranial nerve 3 nerve to the patient's left medial rectus muscle. Activation of the medial rectus muscle causes adduction of the patient's left eye. This is normal conjugate gaze to the patient's right. Before leaving this slide, I wanted you to notice that the MLF is a very thick yellow arrow. That is on purpose. I want to emphasize that the MLF is heavily myelinated, such that saltatory conduction along the nodes of Ranvier occurs to quickly propagate action potentials from the MLF to the nucleus of cranial nerve 3. Think how quickly you can look to the left or right. The right abducens nucleus, in this example, has to communicate with the opposite side of the brain very quickly, so both eyes can look to the right. Thus, the MLF must be heavily myelinated. Making another connection, the myelin of the MLF is formed by the oligodendrocytes that wrap around the MLF. In multiple sclerosis, oligodendrocytes are destroyed, leading to demyelination. Demyelination of the MLF results in an internuclear ophthalmoplegia, as we will see on the next slide. Now, let's look at a patient with an internuclear ophthalmoplegia. Again, let's ask our patient to look to their right. This activates the left frontal lobe eye field, which sends projections down into the brainstem to the contralateral side of the pons to activate the right PPRF, which then activates the right abducens or cranial nerve 6 nucleus in the right pons. The right abducens nucleus then sends out its two key projections. The first is along the right cranial nerve 6 or abducens nerve fibers to the patient's right lateral rectus muscle to cause abduction of the patient's right eye. The second projection from the right abducens nucleus is the left MLF. Again, the MLF is named for its destination, which is on the left. Specifically, the left midbrain, where cranial nerve 3's nucleus is located, which would send projections normally along cranial nerve 3 fibers to the patient's left medial rectus muscle to cause adduction of the patient's left eye. However, there is a lesion in the MLF, such as from demyelination in the setting of multiple sclerosis, that blocks this pathway. And so, the patient's left eye cannot adduct. This is called a left internuclear ophthalmoplegia because the left MLF is damaged, leading to inability of the left eye to adduct. You must realize that damage to the MLF causes ipsilateral adduction issues. So a left MLF means the left eye cannot adduct. That understanding will get you a point on test day. So pause this video and go look at yourself in the mirror and repeat to yourself, the MLF is responsible for adduction of the ipsilateral eye. I'm not joking, seriously. Go do that and come back. I will be waiting. Okay, friends, welcome back. So, not only do we see that the patient's left eye cannot adduct, but the patient's right eye starts to dance back and forth as it realizes that it is out of alignment with the left eye. It might look something like this. This is called nystagmus, as the brain realizes that the eyes are out of alignment and rapidly pulls the eye back to the midline, then abducts it again and again and again in its hopeless efforts of adducting the failing left eye. Well, it's not going to happen because that medial longitudinal fasciculus on the left is gone, so there is no hope for lateral conjugate gaze to the right in this patient. To remember the features of an internuclear ophthalmoplegia, use its abbreviation INO to remember ipsilateral adduction failure, nystagmus opposite. Before we leave this slide, I want to make a key point, and that is that convergence is intact in patients with an INO. What is convergence, you ask? Well, you ask the patient to follow your finger towards their nose as shown between the eyes above. The patient, even with an internuclear ophthalmoplegia, will be able to adduct both eyes like this. Wait, Johnny, how is that possible since the patient's left MLF is damaged? Well, friends, the patient's cranial nerve 3s are functioning just fine, and through other neural circuits, the medial recti of both eyes become activated and adduct both eyes. Thus, convergence is intact. An internuclear ophthalmoplegia is a partial gaze palsy because only one of the two eyes is not moving correctly. What if both eyes do not move to one side? That is a complete gaze palsy. Let me show you how this can happen. Let's ask our patient to look to their left, and as you can see, the patient can look to their left. Resetting the eyes, let's see if that patient can look to their right. As you can see, both eyes cannot look to the patient's right. Looking at our neural circuits, the inability of the eyes to look to the right may be caused by damage to the pons to the right PPRF or the right abducens nucleus. Note it is damage to the abducens nucleus, not abducens nerve, because the abducens nucleus sends projections bilaterally to the right and left eye to coordinate gaze. A key point is that the pons controls ipsilateral gaze coordination, such that the right pons coordinates gaze to the right and the left pons coordinates gaze to the left of both eyes due to bilateral projections from the abducens nuclei located in the pons. Now, let's see if you really understand these neurocircuits with this patient presentation. Again, let's ask our patient to look to the right and watch what happens. What is the diagnosis? This finding is caused by damage to the left MLF, causing a left INO, which can be recognized with the INO mnemonic of ipsilateral adduction failure, as the left eye cannot adduct, nystagmus opposite, as the opposite eye is rhythmically beating due to being out of alignment with the patient's left eye. Now, let's reset the eyes, and then ask the same patient to look to their left, and nothing happens. This patient is unable to look to their left. What is the diagnosis? This is a left PPRF or cranial nerve 6 nucleus lesion, as both structures in the pons are responsible for coordinating ipsilateral gaze. That is, the patient cannot look to the left because the left pons is damaged, either the left PPRF or cranial nerve 6 nucleus. If these findings were found in the same patient, that is, a left INO and a left complete gaze palsy, this is called the 1.5 syndrome, which is caused by damage to the ipsilateral MLF and pons, that is, left MLF damage and the left pons being damaged, as was demonstrated here. This is likely low yield, but if you understand the 1.5 syndrome, you have mastered the neurocircuitry involved in conjugate gaze. If you missed it, do not stress. Understand a standalone INO cold and you will be golden on test day. Friends, we have covered a lot in this module. Let me give you a gaze palsy table for studying purposes. First, you need to know the syndrome of an internuclear ophthalmoplegia, which is a medial longitudinal fasciculus and cranial nerve 3 communication issue, such that the medial longitudinal fasciculus cannot communicate with the ipsilateral cranial nerve 3 to initiate adduction of the eye on conjugate gaze. For the boards and the wards, this commonly arises in multiple sclerosis patients whose disease is characterized by loss of oligodendrocytes that myelinate central nervous system structures, such as the MLF, which then becomes demyelinated. Know that an INO is named for the eye that cannot adduct, and use INO for its mnemonic of ipsilateral adduction failure, nystagmus opposite, to recall the features of an internuclear ophthalmoplegia. Additionally, I want to note that multiple sclerosis can cause a bilateral INO where both eyes cannot adduct on conjugate gaze. These have the same features of a single eye internuclear ophthalmoplegia, but occurs in both eyes. This makes sense as multiple sclerosis causes demyelination and, as such, could demyelinate both MLFs. Next, we didn't cover this in great detail, but I do not want you to confuse a cranial nerve 3 palsy with an INO, as an INO is characterized by MLF and cranial nerve 3 communication dysfunction due to MLF damage. A cranial nerve 3 palsy is often listed as a distractor and answer choices to confuse you. Just know that a cranial nerve 3 palsy can be caused by ischemia, a posterior communicating artery aneurysm, and uncal herniation, among other things, and results in an eye that is down and out with or without pupillary dilation. Please see my video on pupillary dilation for these details. Next, a cranial nerve 6 or abducens nerve palsy is classically caused by conditions that result in increased intracranial pressure. Classically, this occurs in a patient with idiopathic intracranial hypertension, which is also called pseudotumor cerebri. A cranial nerve 6 lesion is named for the eye that cannot abduct due to failure of the ipsilateral abducens nerve on lateral gaze. In continuation, if the nucleus of cranial nerve 6, not its fibers, the nucleus specifically of cranial nerve 6, or the PPRF, in the pons is damaged, such as from a stroke in the pons, this results in a complete conjugate gaze palsy where the patient cannot look to the side of the lesion. That is, the left pons and its components, the cranial nerve 6, nucleus, and PPRF, coordinate leftward gaze, while the right pons coordinates rightward gaze. Next, the 1.5 syndrome occurs with a lesion in the same side such that the lesion is either in the nucleus of cranial nerve 6 or the PPRF and the MLF, but all of these occur on the same side. This makes sense as these structures are located in the pons, so a lesion in the pons could damage the left PPRF or left cranial nerve 6 nucleus and the left MLF, leading to a 1.5 syndrome, which leads to an internuclear ophthalmoplegia and a complete gaze palsy on the side of the lesion. Lastly, if a frontal eye field is damaged from a stroke, then both eyes will look to the side of the lesion. So if the left frontal eye field is damaged, the right frontal eye field will operate unopposed, and the eyes will be pushed over to the left, looking at the side of the lesion. Alright folks, it's time for a flash quiz. The question reads that a 30-year-old female comes to the clinic for evaluation of various neurological signs and symptoms that have come and gone for several years. Today she says that she has double vision when looking to the left. So to test her conjugate gaze, you asked her to look to the left with the findings shown in the image above. What kind of gaze palsy does she have, and what condition should she undergo evaluation? A. Left internuclear ophthalmoplegia, multiple sclerosis. B. Left internuclear ophthalmoplegia, vascular dementia. C. Right internuclear ophthalmoplegia, Huntington's disease. Or D. Right internuclear ophthalmoplegia, multiple sclerosis. The correct answer is D. This patient has a right internuclear ophthalmoplegia and should be evaluated for multiple sclerosis. Multiple sclerosis is suspected because this patient has an INO and because she has had various neurological signs and symptoms that have come and gone, relapse and remit you might say, for several years. She has double vision on leftward gaze because her right INO does not allow her right eye to adduct. So this patient likely has demyelination of her right medial longitudinal fasciculus. Let me show you more about this on the next slide. Here is that same patient from the last slide with the right internuclear ophthalmoplegia due to damage to the right medial longitudinal fasciculus. I labeled what is the patient's right and left and highlighted the site of the lesion. Based on what we discussed, pause this video and go through the neurocircuitry again in this diagram to make sure you understand why a right MLF lesion leads to a right INO, which leads to impaired adduction of the right eye. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Know that an internuclear ophthalmoplegia is named because there is a between nuclei eye palsy ophthalmoplegia due to disrupted communication between the nuclei of cranial nerve 6 and cranial nerve 3 due to damage to the medial longitudinal fasciculus connecting the two. Use the mnemonic INO to remember the name internuclear ophthalmoplegia and its features such that a lesion to the ipsilateral MLF leads to ipsilateral adduction failure and nystagmus of the opposite eye. The MLF is named for its destination, such that the left MLF arises from the right cranial nerve 6 nucleus, and damage to the left MLF leads to a left internuclear ophthalmoplegia. Next, do not confuse internuclear ophthalmoplegia with a cranial nerve 6 nerve fiber lesion. Look at the stuck eye on conjugate gaze. If the stuck eye cannot abduct, then this is an ipsilateral cranial nerve 6 nerve fiber lesion. If the stuck eye cannot adduct, this is an ipsilateral medial longitudinal fasciculus lesion, that is, an internuclear ophthalmoplegia. In patients with an INO, suspect multiple sclerosis, especially if they have bilateral internuclear ophthalmoplegias. Lesions to the pons, specifically the cranial nerve 6 nucleus and or the PPRF, produces a complete ipsilateral gaze palsy. For example, damage to the left pons means that the patient cannot look to the left, but they can look to the right. Conversely, a lesion to the frontal lobe eye field produces contralateral complete gaze palsies. For example, damage to the left frontal eye field means that the patient cannot look to the right but can look to the left. This was a lot of material, folks, so be kind to yourself when learning it and relearning it. It's a cycle, and by continually committing to learning as much as we can day in and day out, we will better be able to serve the patients who come under our care. So friends, if you enjoyed this lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always remember, there is a great big beautiful tomorrow.